Good morning, everyone, and thanking the organizers for giving me this opportunity to speak on something which is a surgeon-friendly but a medical oncology topic. So I'll just go in brief over the Keynote 671 trial, which was a randomized double-blinded phase 3 study of pembrolizumab or placebo plus platinum-based chemotherapy, followed by resection and followed by adjuvant immunotherapy plus oblique placebo. So I have to thank the MSD group for helping me out with some slides. The reason we are talking a lot about lung cancer and we have this 7th lung year-end review is because lung cancer is becoming more and more prevalent. It is one of the deadliest cancers with maximum mortality. And the 5-year survival rates, in spite of all good efforts, are still ranging between 53% to 60%, even for as early as stage 2 cancers. And for stage 3, they dropped to less than 40%, in spite of a lot of advances of treatment which we have been seeing in last decade or so. As per literature, among patients with stage 2B and 3A who underwent primary surgery, the overall median survival is around 76 odd months. And approximately 2/3 of the patients actually experienced a recurrence of disease during this period of follow-up. Neoadjuvant chemotherapy has been proved to be better tolerated, and it does have measurable benefit in overall and recurrence-free survival. The improved 5-year survival was around 5%, and improved recurrence-free 5-year survival was 6%. Similarly, the adjuvant chemotherapy also did help patients in around 5% improvement in overall survival. But that was about it. And especially with patients who have got N2 disease, the survival has been shown to be very meager of 25% for N2 disease and surgery, 5-year overall survival. And the adjuvant platinum chemotherapy just improves it by around 5%. So basically, we need something more than chemo, and that is what has, I think, led to researchers going to immunotherapy. So neoadjuvant immunotherapy does trigger a broad T-cell response, and it is expected to eliminate undetectable residual micrometastatic disease. And also, it has in the adjuvant setting, it does allow the entire environment of the body and the homeostasis to be more of anti-metastatic to prevent recurrence. These were the kind of effects were expected, and on the basis of these, the Keynote 671 of the trials. It was the basis of the trial was patients with resectable stage 2, 3A or 3B as per the ACC 8th edition, and it was designed to evaluate the effect whether we add pembrolizumab in the neoadjuvant along with chemo and in the post-op setting with adjuvant. Did it help in improving event-free survival and overall survival? So patients, the study included around 797 patients. They underwent 4 cycles of neoadjuvant therapy with pembrolizumab plus cisplatin oblique placebo, followed by surgery and followed by adjuvant phase up to 13 cycles, that is 9 months of immunotherapy oblique placebo. The endpoints were event-free survival and overall survival, and the secondary endpoints were pathological complete response, maximum partial response, quality of life, safety, and perioperative complications. This is a very busy slide, and I have only 7 minutes. So basically, inclusion criteria and exclusion criteria were quite well defined. The median follow-up of the study till 2022, which has been started in 2018, has been 25.2 months. And in the Pembro arm, 307 participants underwent surgery alone, 18 went in study surgery and in study radiotherapy, 17 in study radiotherapy alone. Basically, what I'm trying to say is that they were quite well matched. The characteristics, again, were quite well matched. It was a double-blinded study, and the data cutoff has been July 29, 2022. Going straight forward to the surgical procedures which were performed, 256 of the pembrolizumab patients underwent lobectomy with 238 of placebo arm. Overall of 30 days, all-cause mortality was 6% in the pembrolizumab versus 2% in the placebo arm. So that was one thing, but not proven to be statistically significant. This is the surgical procedures performed during the in-study surgery group. So when we go to the results, we found that the event-free survival was statistically significantly better in patients who have been given neoadjuvant pembrolizumab plus followed by adjuvant chemotherapy instead of placebo. The p-value was less than 0.001, and the reason, sorry. So the events which contributed to the events, the survival cutting short was disease progression recurrence in 94 patients of pembrolizumab, local disease progression preventing surgery none. So they all responded well enough to undergo surgery in the after neoadjuvant setting. Inability to resect the tumor was way less in pembrolizumab compared to placebo, 5 versus 15, and death, though, was a little more in the neoadjuvant immunotherapy arm, which led to a shortening of the event-free survival. So it did prove that the disease progression, the inoperability, the ability to resect, everything was much less in the pembro arm compared to the placebo. The overall survival we have not yet reached. The study we expect in next 3 to 4 years to get the overall survival benefit, but it is tending towards a better overall survival for patients of the pembro arm. Similarly, the pathological complete response and the maximum partial response rate with less than 10% viable tumor cells, the p-values of pembro arm is much significant. Both are less than 0.0001, suggesting that adding of neoadjuvant pembro is a better alternative to neoadjuvant chemo alone. The safety has been equivocal in both, has been comparable, and the summary of the adverse events have been also comparable. So it's been showing that there's no specific difference in patients who have, this is the last slide, who have not received immunotherapy in perioperative phase. The take-home messages would be that yes, the resectable patients of stage 2, 3A and 3B, if feasible, neoadjuvant combination of pembrolizumab plus chemotherapy followed by resection and adjuvant immunotherapy in the following 13 to 15 settings at least have been shown to be statistically significant and clinically meaningful improvement in the event-free survival, the complete response rate, as well as the maximum partial response. This trial is entirely based on a surgeon's perspective from our side, whether it is helping to turn the unresectable towards the resectable post-neoadjuvant therapy. I do think so, and this is what the trial is hinting. Though overall results are yet awaited, but we do think that the tide is turning towards more surgical options in stage 3 3B patients. Thank you.